Hi, good afternoon, everyone. It's my great privilege to introduce our speaker for today, Dr. Sujay Paudel. He's one of our fellows that we were fortunate enough to keep within our nephrology transplant practice. Dr. Paudel got his Bachelor of Medicine and Bachelor of Surgery in Kathmandu, Nepal. He's actually kind of a worldly man and also did some time in China and can speak some Chinese. And then he also has a background with some endocrinology training. He ultimately came to the States and did his nephrology fellowship at Loma Linda University of California. And then he did a fellowship with us in transplant nephrology just last year. As we've been going through time, we've been noticing that there are these transitions that are occurring in nephrology between general nephrology and transplantation. And so he'll be presenting to us today on the transition of the stable transplant recipient back to the community. I welcome Dr. Paudel.
Thank you, Dr. Desai, for the introduction. Good afternoon, everyone, and I welcome you all here today. So I will be talking on this topic, transition of the stable transplant recipient back to the community. So I will be talking briefly on the rationale behind doing that, and then we'll talk briefly on the immunosuppressive management and the side effects and some drug interaction with some of the immunosuppression that we encountered in our daily practice. We will talk briefly about the comorbidities that are involved in the kidney transplant patients, and also we'll talk briefly on the policies that are already in place, and some of the policies will be taking place later on this year. So this graph shows that the number of transplant patients, they're increasing each and every year. So this is a 10-year graph. We can see that it was like the new transplant patients were around more than 15,000 in 2013. And when we look at 2023, in a 10-year period, it has gone up to like 25,000, almost close to 30,000. So each year it's increasing, and that's a good sign. But when you look at the number of transplant nephrologists, only we have like around 800 transplant nephrologists that are identified by the American Society of Transplantation. The number may be a little bit higher than that because not all of the transplant nephrologists would be registered to that society. But anyway, that's not a enough number to take care of all the transplant patients that we have currently. Now, when we talk about transition of patient back to the community or to the to general nephrology, it should be a very thoughtful one. It should be a thoughtful coordination. It should start from pre-transplant care, transplant, and then post-transplant. It should be a coordinated way. Again, coming back to the data, we can see here, that around like if we see the new transplant to physician ratio, it's like 1:35. And the prevalent transplant patients to physician ratio is like 1:383, close to 400. And when we compare this to the other transplant physician, the number are definitely very high when we compare with the transplant nephrologist. So there were some changes recently. So kidney allocation system, I think it came into place in around 2019. With that change, there was a share of kidney transplant patients to most of the transplant center, but there was more allocation time and more travel time involved with that change. So that has led to more cholestemic time in the organs, and this may be one of the factors that we see a lot of like delayed graft function in the transplant population. These have all increased the post-op patients longer stay and busier clinic and more readmissions, and we can see here that the transplant nephrologist with the red file will be seeing a lot of more patients. And the Kidney Health Initiative was initiated with the aim to prevent, detect, and delay the progression of kidney disease. The main goal is to make sure that 80% of new kidney failure patients in 2025 are either receiving home hemodialysis or they're receiving a transplant. The goal is to double the number of kidneys available for kidney transplant by 2030. So that will increase more referral, more evaluation, more pre-transplant patients, more transplant offers, and again, the chances that the transplant nephrologists will be overburdened with patients are very high. So the Kidney Care Choices model, it is initiated by by the Medicare and Medicaid to improve the quality of care to the kidney patients, especially with CKD stage 4, 5, and ESRD patients. So there are different healthcare modules we can see over here. So kidney care choices model is to make sure that we can delay the onset of dialysis. So taking better care of the patient at stage 4 and 5, we can do that. The other module is ESRD treatment choices model. So the goal here is to encourage the use of home hemodialysis for the kidney patients, and also increase the access to kidney transplantation. Now, there is another healthcare model which is known as increasing organ transplant access model, which is a proposed mandatory model. There are like 50 transplant centers that will be participating in that model. So it will start this year by July, and it is a 6-year pilot project program. So the main aim of this model is to increase the access to kidney transplantation. So overall, this model aims to increase the better care of the CKD patients and more access to the transplant for those patients. So the IOTA model, the main goal is to improve quality of care before, during, and after transplantation, and we assume that it will increase patient engagement with that model. There will be public posting of patient selection criteria for transparency, and then they will be providing incentive to transplant center for improving communication with patients, providing transportations, home health, and mental health services. There is also improved care coordination with nephrologists and ESRD facilities, so they may be engaged in financial arrangement for enhancing post-transplant care and outcome. So the overall goal is to maximize the use of deceased donor kidney transplant and identify more living donor so that they can increase the pool of kidney transplant kidney for the kidney transplant patients. So when we talk about when we take care of the kidney transplant patients, it is a unique medical care. So the patients, they already have a wide range of pre-existing medical conditions, and on the top of that, using the immunosuppressive medications makes things more complex. So their problems are more prevalent, they are more atypical, and they are more severe in presentation than the general population. I just want to share one more thing over here, that the kidney, the KDIGO guideline, they recommend that all kidney transplant patients should be considered as CKD, irrespective of what the eGFR is. We may have seen this race in an Olympic. So the four runners will take place, and each runner will do their best to pass the baton from one runner to another runner, so that with a common goal of getting a gold medal. Now we can relate this to somewhat to our transplant, to care of our transplant patients. What I want to point over here is that it is not like just one center dedication to make this transplant a successful one. It is a multidisciplinary approach with the help from the general nephrology, from the primary care, from the transplant nephrologist, and so on. Now everything starts with a relationship. So better communication between the transplant center and general nephrologist is very important. There were many studies that have shown that at most of the time the communication is suboptimal. And therefore, this is important, and it should start before referring the patient for the transplant, and it should continue, and even after the post-transplant, it should continue. I found this one interesting. So this was a survey done in 2020. They wanted to find the factors, or they wanted to find the predictors that would increase the likelihood of communications between the general nephrologist and the transplant center. So what they found in that study is that the general nephrologists who have attended more than one transplant-related CME activity in a year, who are working in a group more than 5 nephrologists, and who has more than 50 patients in dialysis, they have a likelihood of communicating with the transplant center. And this is during all various phases of transplantation, in the referral phase listed, and even after transplantations. This was a survey and done in the United States. So out of 197 transplant center, 92 participated in this survey over a period of 1 year. And when asked about their practices regarding graduating the patient back to the general nephrology, they found that 48% of the program would partially graduate, or that means they would co-manage the patient with the general nephrology, whereas 38% would entirely transfer the patient to the general nephrology. That means their care would be shifted to the general nephrology from the transplant center. And 12% of the center say that they would keep the patients and they don't prefer to transfer the patient back to the community. This was the same survey, and here we can see that none of the transplant center would transfer the patients when the post 3 months, less than post 3 months. And most of the transplant center would transfer the patients after 12 months. So out of that, 35% would co-manage with the general nephrology or with the community nephrologist, and 27 would be like without co-management, would be entirely up to the general nephrology, and the transition would start after 3 months, though it's not as like high number. 3 months to 12 months, 38% would be co-management. Will do the co-management with the general nephrology. Now we would like to transfer the patient if they're stable after the transplant, right? So stable for at least 1 to 3 months after the transplant as an outpatient basis. And what defines the stability of the patient, of the transplant patients? We can categorize into like surgical and medical. So surgically, we have like there should not be any issue with the wound. Absence of any wound infection, there is no abdominal collection, all the stand, SD catheter, they are all removed. From the medical point of view, the kidney function should be stable. The creatinine should be stable. There should not be any active rejection going on, and we should have a stable plan for the immunosuppressive drug regime. There should not be any infection, no active cardiac disease. Blood pressure should be stable. Stable electrolytes and coagulation parameter. Anemia, leukopenia, thrombocytopenia should be resolved. Now, when asked about the primary rationale for graduating patients back to their local nephrologists, this was the same survey done here in the United States. Distance travel is one of the most important factor that we would like to graduate the patient back to their local nephrologist. And they want to maintain a referral base followed by continuity of care. Now, we can't deny that there is overburden with the patient in the transplant center, so this is one of the reasons for graduating patient as well. And apart from that, time away from work, the patient may have to take leave for the follow-up visit if they live far away from the transplant center. So 61% believe that transition of care is necessary, and then around 39% they believe that it's not necessary. And this survey were participated by the nephrologists. Most of them were nephrologists, 70%, and 17 and the rest were surgeons and their staff. Okay, when we talk about the immunosuppressive agent, as there are literature that says that it is an art and science of medicine, so we should be very careful with the immunosuppressive agents because we want to prevent rejection, but at the same time we don't want to overexpose the immunosuppressive agent so that to cause toxicity. So it's a very thin line. The margin of error is very less while dealing with this immunosuppressive agent. So we can divide this into induction phase and then maintenance phase. So in the induction, apart from giving steroids, these are the medication that we use. These are usually given intraoperatively before connecting the kidney to the new blood vessels. It depends. It's center-based, and it depends. So here in Northwestern, we usually use Campath for the induction. Well, in most part of the center, I think it's thymoglobulin that are more commonly used. And we use Simulect if the patient is more than 65 years, or if the patient had a previous history of malignancy, or the patient was treated with cyclophosphamide for some reason. So maintenance immunosuppression, CNI is one of the main medication that we used along with mycophenolate. So in the CNI, we have two groups, tacrolimus and cyclosporin. Tacrolimus is the main drug that we use on the CNI. We have like two forms of tacrolimus. One is the immediate release, which we give like 12 hourly, and the other is the extended release, which we give in once a day. The target level, again, it's center-based. It's not the same in every center, but in most of the center initially, they would maintain a trough of 8 to 10 nanogram per ml. And after a couple of months, usually after 3 months, we would start decreasing the target. And after the first year, we would maintain the target at around 5 to 7 nanogram per ml. We would decrease further the trough level if the patient has significant infection, like CMV virus infection or BK viremia, and if the patient has a malignancy. Now, cyclosporin, it is a second line of drug under CNI. We would switch to cyclosporin if the patient had like some side effect of tacrolimus, as for example, neurotoxicity, or the patient was diagnosed with new onset diabetes, or the patient complains of alopecia. In that condition, we can switch to cyclosporin. And when we do that, the initial dose is 6 to 10 milligram per kg body weight. Again, we look at the trough for this medication to adjust the dose. Initially, it's maintained at around 200 ng per ml, and then after the first year, it's 50 to 75 ng per ml. When you talk about the adverse effect of CNI, we can divide into renal manifestation and non-renal. Renal, we all know that nephrotoxicity is something that we are always worried about with the CNI. So long-term, they can cause chronic interstitial fibrosis. CNI can cause hypertension, they can cause hyperkalemia. One of the most unique side effects of CNI is CNI-induced thrombotic microangiopathy. So it can be renal limited. That means it can be diagnosed with the kidney biopsy, and sometimes it can be systemic, which is similar to thrombocytopenic purpura. Then non-renal manifestation, though tacrolimus and cyclosporin, they fall on the same group, but they have a different side effect. Tacrolimus will cause alopecia, whereas cyclosporin, it causes hypertrichosis. It can cause gynecomastia in men due to increased prolactin level, and we should be careful if the patient has hyperuricemia, gout, and hyperlipidemia. And there is one severe side effect of CNI, which is known as posterior leukoencephalopathy, when the patient can be presented with altered mentation, headache, and seizure. So drug interaction with CNI is very common. I just want to remember during that COVID era, 2021, most of the patients were given Paxlovid, and they would land up in the emergency department with altered mentation, AKI, and hyperkalemia, and the trough level of tacrolimus would be around like maybe 50, 60, 70. So it is very important that we know that, what causes the interaction with CNI. And any medication, this is not an extensive list. This is the most commonly used one, but there are extensive list of medication that can interact with CNI. So we should check if they have an interaction with the CNI before starting medication. And medication that can increase CNI, like antifungal medication and diltiazem and verapamil, we should decrease the dose of the CNI, and then we should be checking that level on a regular basis. Drug that decreases the CNI level, we should increase the dose, and again we should check on a regular basis. So we should be very mindful while starting and stopping those medications that can interfere with the CNI level, because if the patient has like low level of tacrolimus, the chances of rejection would be high. Under anti-proliferative agent, which is one of the most commonly used immunosuppression along with the CNI, we have two medications under this group: azathioprine, which is the first immunosuppressive agent that was used widely and in the transplant population, but now we don't use as a first line treatment. We all know that it has got drug interaction with other medication that inhibits xanthine oxidase, like allopurinol. Before starting this medication, we should check the TPMT, and the most common side effect is nausea, vomiting, and we should check for the liver function test before as a baseline, and then on a regular basis to make sure the patient doesn't have that hepatitis. Mycophenolate, we have two versions. One is the Cellcept, one is the enteric-coated, which is known as Myfortic. So the most common side effect of mycophenolate is GI side effect. The patient may complain of nausea, vomiting, and diarrhea, and the other side effect would be bone marrow suppression. The one thing that we should be mindful about this medication is it is contraindicated in pregnancy. So if the patient is planning for a pregnancy, we should switch to azathioprine before conception. And with the myfortic, sometimes if the patient has a GI side effect, what we can do is it's usually dose dependent, so we can decrease the dose, or we can space out the mycophenolate. And if it does not work, we can even switch to myfortic. But if the patient has diarrhea, we should always think about the infectious cause of diarrhea in a transplant patients. So this is the new kid on the block. So this was approved by the FDA in 2011. So this is the only medication that is, this is only available in intravenous infusion. So it blocks, it's a co-stimulator blockage, so it blocks CD80 and CD86, so that the receptor from the antigen presenting cell, it does not interact with the T cell with the CD28. And thus it inhibits the signal 2 pathway, and it is usually used as a CNI sparing agent. Like if the patient has a CNI toxicity, like in the biopsy we see a lot of fibrosis, then this is the agent that we would like to switch to. There were studies that show that it can improve kidney function in the transplant population. There was a trial known as the Benefit and Benefit Extended trial. However, they found that there is a high grade of cellular rejection with belatacept. Now, the trial has a limitation because it was compared with the cyclosporine, but we usually use tacrolimus as the most common agent for immunosuppression. We should be very careful. We should check for the EBV status for the patient. And if the patient is EBV seronegative or with the unknown status, we should not start the medication because there is a high risk of developing PTLD in these patients. So this is a 10-year data comparing the GFR with the cyclosporine and the belatacept. Here we can see on the top one, this is the belatacept group, and consistently it has shown that the GFR is superior than the cyclosporine group over the period of 10 years. We can see the difference here between the belatacept and the CSA in terms of the GFR. So apart from CNI sparing agent, we can also use this medication if the patient has like antibody-mediated rejection. If the patient has like de novo, the study have shown that it decreases the incidence of de novo DSA formation in those patients. It can also be used if the patient has a chronic active antibody-mediated rejection. So it is given once. Initially, it can be the loading dose we can give like once a week for around like 4 weeks, and then the patient will take this medication as an infusion at an infusion center every 28 days. And the infusion center, they are done on most of the NMH infusion center, and can be given in a metro infusion center, which are all over. Now, there are certain benefits of using belatacept. It is given once a month. There is no drug monitoring. And there is a fixed dose for every patient, right? And it can also be beneficial for someone like who is not very compliant with the medication. So it can be given once a month, and then we know if the patient is taking that medication or not. It can also be beneficial for someone who is not very compliant getting the labs. So when the patient goes for the infusion, we can ask the nurse to get the labs during that time. So another group of immunosuppression is mTOR inhibitor. It can also be used as a CNS sparing, or it can be used if the patient has been diagnosed with some certain malignancies like renal cell carcinoma, skin cancer, and in other cancers as well. We have two here, sirolimus and everolimus. What I want to focus on this medication here is that it has a profound inhibitory effect on wound healing. So if the patient is undergoing surgery, if it's a minor surgery, we can just keep using the mTOR inhibitor. But if it's a major surgical, if it's a major surgery, then it is advised to at least stop the medication 2 weeks prior to the planned surgery, and if not, at least 5 to 10 days. And we can use steroid as a bridging immunosuppression for those patients. And if it is an emergency surgery, we can stop as soon as we know about that. So this is an overview of the side effect of the immunosuppressive agent. So we can see here tacrolimus has more neurotoxic effect than cyclosporine. we can also see that the post-transplant diabetes is more prevalent in tacrolimus than in cyclosporine. When we see the mycophenolate, we see that the commonly side effect are the bone marrow suppression, and then the GI side effect. Azathioprine has also a bone marrow suppressive side effect. We can switch to azathioprine if the patient has a lot of GI side effect as well after ruling out the infectious cause of diarrhea. For the mTOR, we talk about that, the wound healing here. And then the other thing is that the mTOR inhibitor, it causes proteinuria. So we should avoid the patients who has already proteinuria for those patients. So each and every patient post-transplant would get a prophylaxis for CMV infection and for the PCV infection. So for the PCV, again, the guidelines, there is not a definitive guideline for all the transplant center, but usually they recommend that for the PCV we can recommend for 3 to 6 months, but it depends. Like previously in California, they would use this medication Bactrim for at least 1 year, but here I think we used indefinitely for the prophylaxis. As an alternative, we have other medication that can be used. As for example, if the patient has sulfur allergy or is does not tolerate Bactrim, maybe they are having a lot of bone marrow suppression, we can switch to Dapsone, pentamidine, and atovaquone. The most common side effect, we know it's leukopenia and the skin disorder, including Stevens-Johnson syndrome. Now, for the CMV prophylaxis, we use valganciclovir. We use at least for 6 months. The patient who is, we categorize the recipient into high risk and low risk. So high risk is when if the donor has CMV IgG positive, but the recipient is IgG negative. Anyway, we give this medication for at least 6 months post-transplant. This is very common, electrolyte abnormalities after the transplant. Hyperkalemia can be due to multiple drugs, CNI, Bactrim, S and ARB. And then the other electrolyte imbalance that is very common is hypomagnesemia, which can be due to tacrolimus and can be due to PPI. So that we treat the patient with oral supplement if the level is less than 1.5, and we avoid the level more than 2.2 to avoid magnesium-induced diarrhea. So that there are some few common comorbidities in kidney transplant recipients. We all know that in the CKD or ESRD patient, cardiovascular is one of the main cause of mortality. After the transplant, it does decreases, but it is still higher than the general population. So we can divide the common comorbid conditions into 3. These are the most common comorbid conditions after the transplant: cardiovascular, infection, and malignancies. So in the cardiovascular, acute coronary event that occurs intraoperatively or within 3 months, there are some high probability there are some causes that can cause a high probable cause of coronary event during the initial phase of the transplant. These are like if the patients had a pre-transplant diabetes, if the patient is obese, if the patient had previous kidney transplant, if the patient had proteinuria, or they had moderate homocystinemia, high CFR. These are the high risks for the acute coronary event immediately after the surgery, especially within 3 months. There's also high risk of peripheral vascular disease and metabolic disorder. They're very common after the transplant. The patient may have ongoing or de novo hypertension. Diabetes is very common, maybe because the patient starts eating very well, they gain weight, and then due to certain medications like tacrolimus. Infection, we all know opportunistic infection is very common post-transplant, and among those, cytomegalovirus, Zika virus. Urine tract infection is very common as well. Malignancies, skin cancer is very common in the post-transplant patients, breast cancer, cervical, prostate, and colorectal cancers. And we should not forget about PTLD in transplant populations as well. So when we talk about the AKI in transplant populations, we can still divide into pre-renal, renal, and post-renal. So in the pre-renal, it can be due to decreased kidney perfusion, due to volume depletion because of diarrhea that can happen because of the CMV or because of the infection. Renal artery stenosis and calcineurin inhibitory toxicity can cause AKI as the cause of pre-renal. Obstructive cause, it can be due to urethral strictures. BK virus infection is very common that can cause urethral strictures. Bladder dysfunction and bladder outlet obstruction is something that we should know about. And intrinsic kidney injury, acute cellular rejection or antibody-mediated rejection is always on the top of the list. So the patient will get a kidney biopsy if we don't have if you have a unexplained cause of AKI, and if you're suspecting cellular rejection or any antibody rejection in those patients. Drug toxicity is common as well. CNI, we'll talk about that. Antibody can cause infection, any sort of infection can cause AKI, especially transplant pyelonephritis and BK virus. And we should also be mindful about the recurrent disease that can occur in the transplant population. And we would prefer for a kidney biopsy if there is any unexplained AKI in kidney transplant patients. So these are the more the common malignancies that we can see in the transplant population. Oral cancer, it could be pharynx, larynx, or oral cavity. Urogenital cancer it can be both in the female and male patients. Kaposi sarcoma, Hodgkin's and non-Hodgkin's lymphoma. Renal cell carcinoma is very, very, very common in the native kidney, and we talk about the skin cancer as well. Now there are surveillance that is recommended by AST. So every patient should get an dermatology evaluation every year to rule out skin cancer, and especially who are the patients that are at high risk for urogenital malignancy are those patients who have received prior chemotherapeutic agents such as cyclophosphamide or have had a history of analgesic nephropathy. Female patients, renal transplant patients should have yearly pelvic exams and pap smear to rule out cancers. And again, we talk about that lymphomas, including PTLD, should be on the differential diagnosis. There are recurrent and de novo disease. So these are the diseases that can recurrent in the transplant population: FSGS, IgA nephropathy, membranous proliferative glomerulonephritis, and hemolytic uremic syndrome. So the patient should be monitored for the proteinuria and hematuria on a very regular basis for those patients. Now, what are the situations like when the transplant center would be consulted? This is not an extensive list, but yes, definitely when there is suspicious for patients' non-adherence to rule out rejections, right? And then if there is any major alteration in the immunosuppressive regime, obviously, if we're suspecting there is any rejection in the patient, if there is unexplained AKI that we talked about previously, if there is any significant increase in the baseline proteinuria or there is new proteinuria, if there is swelling or pain in the allograft site, if there is thrombocytopenia or hematuria, if the patient was recently hospitalized for any reason, if we are suspecting malignancy, that should be, we should refer that patient to the transplant center. And if the patients are planning for pregnancy, this is very important. We should switch the patient mycophenolate to azathioprine prior to planning pregnancy. And definitely when the patient returns to dialysis therapy or the patient kidney, there is an allograft failure and the patient should be relisted for transplantation. So there are advantages of post-transplantation care by the community nephrologists. We talked briefly in our previous slide. They have a very good relationship with the general nephrology. This is something that we can't deny. Travel time, which is very important. Most of the patients, they complain that they have to travel, for hours for the follow-up, and it will enhance the continuity of care as well. And the general nephrology or the community nephrology, they are very familiar with the medical history and conditions, and they can reassure the patient that you are close to me, and if there is anything that's urgent, we are here for you. And most of the patients, they would skip the normal follow-up because of the time that they have to travel. They have to get off the work. They have to find a hotel there, stay here. So for all these factors, there is an advantage of post-transplant care by the community nephrologist. Now, what should the nephrologist know? I think they should be aware of how often to order labs and target trough. We can help with that. I think that the transplant center have their own sort of guideline for that. And then we should be aware of the drug interactions and should have an access to centers resources like the EMR and what the protocols are. If the patient is adherent to medications and what is the coverage of the medications, and they should recognize the complication post-transplant and make sure that the patient has access to centers EMR, that is the patient portal like MyChart. Now, for a successful transition, there are multiple factors that will come into play. We talk about communications and good relationship with the community nephrologist or the general nephrologist, and then there should be a clear role and responsibilities between the transplant center and the general nephrologist. And the documentation should be very good. It should start from pre-transplant, transplant, anything. Excuse me. During the surgery and the surgical complications, I will talk in detail in my next slides. Lab and frequency visits, medications. It is not a generalized, documentation, but it's individualized based. So every patient is different. So we should talk to the general nephrologist in detail regarding that. And if the general nephrologist or the community nephrologist has access to the transplant center, that's a very plus point. Especially with the transplant coordinator, they are like very in good touch with the nephrologist. This is something that is beneficial for the patient. Sorry for this busy slide. So what I want to focus over here is that there are a lot of information that we need to provide to the community nephrologist or general nephrologist. So transition of care is not a one-day term. Like it should be a very thoughtful coordination that we have discussed previously. So we should provide with all the pre-transplant record, like what was, if there are any new diagnosis that occurred, all right? If there was any social issue, if what was the blood type, recipient viral serology of pre-transplant. any positive tests that we need to discuss with the community nephrologist or general nephrologist. Now, transplant procedure records, like during the surgery, if there was anything that needs to be discussed. Donor viral serology is important so that we can keep an eye on that. And surgical record, and if the biopsy was done, time 0 biopsy, we should give that results as well. And detail of the immunosuppressive drug regime regarding the patient is very important. And post-transplant records should be provided. I think these are almost the same. If there is anything that needs to be shared, should be shared in a very open way, and the plan should be shared to the general nephrologist so that we have a plan for the patient, and then the community nephrologist or the general nephrologist can touch base with us if there is anything anything that needs to be discussed. So this is our protocol here at the Northwestern. So I would focus on, like immediately after the transplant, we have like more frequent monitoring of the labs. Now, as the transplant is older, the frequency of labs it decreases, and after 1 year, most of the standard of care labs we do it like on a monthly basis. And there are other labs. It depends on the patient's clinical conditions that may need to repeat it more often. And after 3 years, we can do like every 2 months the standard of care labs. So there may be delay in referring back to the referring nephrologist, and there are few reasons. One of those would be the patient's desire to remain under the transplant center care. And maybe the patient is not very stable, that we talked that in a previous slide. There are a lot of rejections going around. And sometimes it's the transplant center protocol that we saw in our previous slides, that 12% of the transplant center, they would not refer back to the referring nephrologist. Now, what are the reasons for delaying referral back to the transplant center? Again, distance is one of the most important factor, maybe related to insurance coverage issue, or maybe they feel that their transplant center has not many resources, and sometimes the patient would prefer to remain under the care of the community nephrologist. Now, when there is a failing kidney allograft, when the post-transplant patients had a CKD stage 4 or 5, and they are very close to fail allograft, they are more likely to have like more uncontrolled hypertension. They are more likely to have like severe anemia, dyslipidemia, and most of the patients, for some reason, maybe they are not, they are not on some medication, important medications like S inhibitor and erythropoietin. We usually delay starting that medications, and most of the patients may not be even on statins, or maybe we delay starting those medications for those patients. I just want to touch briefly, I know we had a talk before, but just want to touch base, like what are the psychological aspects. Now, failing allograft is something that we would like to avoid, especially the early graft failure. And I think there is a profound psychological aspect that goes with the patient. Not only the patient, even as a physician, if the graft failure is early, we feel bad. And there are a lot of things going around. For example, there is a loss of control. Patient feels like powerless, like they feel like, not motivated. There is loss of coherence. The patient are in a state of shock and confusion. There's loss of certainty. The patients are not certain that they would get a next transplant. They may have to be on dialysis forever. Loss of hope again for the same reason. They're not sure whether they will be eligible for the transplant. Loss of quality of life, which is very important. They will lose the personal freedom they had with the transplant, and then some may feel the loss of transplant team as well. So there are a lot of psychological aspect that goes with the patient. So it is very important that as a team we work together. It's a multidisciplinary approach to prevent early graft loss, so that we can prevent all these complications and reach our common goal for the patient. Thank you. Any questions? Yeah.